Yes, we can. And recording has started.
Perfect. Okay. So, hello everyone. My name is Rodrigo. I'm one of the FY1 doctors working in Leicester, and I'm here to talk to you about risk of bias assessment and quality assessment. I don't like calling it quality assessment because I think it's more of a risk of bias. A paper can still be really good, but be vulnerable to bias. So I think that's a key message that I want to try to get across. So firstly, we're going to go through what risk of bias, what you're meant to be doing when doing risk of bias, what it is, and then afterwards we're going to do a paper together. So by the end of this presentation, hopefully you'll be able to know how to select an appropriate tool to assessing bias, and also how to apply it correctly, and then how to summarize your findings to put it on the paper. So, well, why do we do quality assessment? So, could someone tell me why do we do this? Okay, Veronica, why do we do quality assessments and systematic review?
uh, to determine how whether the papers that we're including are prone to bias, and therefore that is a limitation that then becomes part of our study. We also want to do this a quality assessment to determine whether to even include this paper or whether the conclusions that they draw are not reliable.
Yeah, so not all published paper is actually reliable. Not everything that's out there you can fully trust. And if you get papers that are vulnerable to bias and you put in your systematic review, you could be skewing the results of your systematic review. So the key idea is that things can be very well written, very precise, but they can still be vulnerable to different forms of biases. And that's what we're trying to catch on to here. The definition of a quality assessment is a systematic evaluation of how study design, conduct, and reporting may distort the results. So does anyone know any types of biases? It's fine, we'll talk about them later. But essentially, there's a difference between a risk of bias, which we're focusing more on the internal validity of the study, and if the results are systematically correct or systematically wrong, how well they apply within the context of the study, is different to the overall methodological quality and the reporting quality of the study. So methodological quality is how well the study was designed and how well it's reported. Reporting quality is well how well the paper manages to show its results to its viewers. Yeah, nice. So there are different types of biases. So Hussein, could you tell me a type of bias?
Selection. Oh, it's already there. Selection bias.
Yeah, so selection bias. Selection bias is basically, what is that?
It's bias in terms of like the participants you select for your study.
Mhm. Yeah, so if the groups of the study or the people that include in the study, for some reason or another, they're different from the groups you're comparing to, or to the population that you want to evaluate. So for example, if I select only people that are in hospital, that could be different if I'm trying to look at something for people that are outside of hospital, because these populations are different from each other. And these are very important depending on the study that we're looking at. So for example, attrition bias is if people drop out of the study, we could end up losing important information. For example, in a randomized control trial, if sicker people drop from one arm of the study, that means that maybe we won't find what actually, if the intervention we're testing for is actually good or actually bad, because we're losing a proportion of their population. So it's not just, so we use structured tools just so it's not our own judging whether a paper is good or whether a paper is bad. Because if that's just it, it's not really reproducible. It can be influenced by personal factors, and it's really, really hard. It's really inconsistent between different reviewers. So we use specific tools to ask standard questions so that other people can do it as well, and also to improve our transparency in the study that we're doing. So we will also report on our paper which tools we chose to use, how we applied them, and the results we got from applying them. And there are many, many, many different tools. Does anyone know any tools out there to assess bias?
Robbins one,
Yeah, Robbins one. And what to use Robbins one for?
non-RCTs.
Yeah, so observational studies and retrospective studies, that kind of stuff. What about a different tool? Shiraz, could you tell me a different tool?
Not really, sorry.
No worries, no worries. So I'll show you. So there are many different tools. I put in this slide some of the ones that we commonly use. Uh, so if you want to look at randomized control type trials, you look at Robbins 2. If you want to use the non-randomized or observational studies, use Robbins 1. If you want to use a cohort or case control studies, you can use the Newcastle-Tau scale. Sometimes you can also use Robbins 1. If you want to look at diagnostic accuracy studies, you can look at QUADAS 2. And if you're not really sure, you can always use the Joanna Briggs Institute, JBI, because they have multiple different tools for multiple different study designs. And keep in mind that your study doesn't need to stick to only one quality assessment tool. You can use a diversity of quality assessment tools depending on the question you have and the studies that you have included. But it's very, very important that you're using the right tool for the right study design, because otherwise you're going to be asking questions that do not pertain to the study that you're looking at. Does that make sense?
Can I ask a question?
Yes, of course.
Because I'm new to this, that's why I'm
Yeah.
a little bit confused. Like, how do you know? Do you always follow this table that's on the screen? Like, for let's say study type, you use recommended tool. I don't know.
No. So that's a very, very good question. So it depends. Usually the person that's leading the study would choose a tool. However, it depends on the type of study that you have. So some of them are pretty much a no-brainer to use. So if you're looking at randomized control trials, you'd usually go for ROB2 from Cochrane because it's almost like a gold standard. But if you're using a different type of study, for example, the Lanky study that we published recently, we used a different tool because um, it was comparing the what was the name inter-observer validities and of reliability of things. So there's different tools for different applications. So I just put here an example of common ones that you'd use, but it varies. For example, for educational studies, you use a different tool like the Mirsky tool or whatever. So it varies. Someone who's leading the study will tell you which tool to use, but it's just important that when you're choosing a tool, you have in mind the studies of your review, because otherwise you could be assessing things wrongly. But these are just some common ones. Does this make sense?
Yeah. Also, what is the tool? Sorry, it might sound very basic,
No,
but to
no,
me,
no.
it's like, okay, now how do I get the tool? What is the tool? Is it something am I following, or is it something that you use? Like, I don't know.
Great question, great question. So I'll show you because we're gonna go over one together. But a tool is just a set of questions that you're gonna be asking that specific paper. So it's just a set of criteria that you're gonna go through and see if the paper meets those criteria. I'll show you and it will make more sense. But each of them has different questions that are part of this. Does this make sense?
Yes, it does. Thank you.
Perfect. No worries, no worries. Please, guys, ask questions as we go along. I'll show you a tool and we're going to do a quality assessment together. So, for example, the ROB2 tool, which is for randomized controlled trials, it looks at 5 domains. So, it's the bias of randomization, bias due to deviations from the intended interventions, bias due to missing outcomes, bias in measurement of outcomes, and bias in selection of reported results. So this is very specific to a randomized control trial. If I'm going to apply this to an observational study, the study will instantly miss many different departments because you won't have randomization, you won't report on deviations from intended interventions, it won't report on missing data outcomes. So it's very important you choose the right tool for the right type of study. And then after that, you make an overall judgment on the score of each domain. So we'll do that. I know it sounds a bit abstract now, but we'll do that together. Let me change slides. So the steps to applying a risk of bias tool is first identifying the study design. Is it a randomized control trial? Is it a cohort study? Is it a case control? Is it a cross-sectional study? And then you select the correct tool. Usually one tool per study type. So if you have an observational, you'd use the Robbins 1. If you have a randomized control trial, you'd use the ROB2, etc. And then you answer the questions that the tool is asking you with yes, probably no, or I need more information. Sometimes it's not reported. And based on these predefined rules, you'd make an overall judgment for that domain of the tool. I know it sounds very strange, but we do one together. Then after that, you do an overall judgment for the paper. So, okay, I'll show this later. We'll go over it together. After you're done with assessing all the papers, you should end up with a graph that looks something like this. It's called a heat graph. And essentially, it tells you which domains did the studies meet and which one they did not meet, and then an overall judgment on the study. So if a study does not meet suitable criteria, what can you do to the study? If you've determined through the quality assessment that the paper does not meet, the paper is vulnerable to bias, what can you do with it?
Would you exclude the study?
Yeah, you can exclude the study. That's one of the approaches you can take. What else can you do? Is there a way that you can still keep the study in?
Maybe just acknowledge that there was a risk of bias in one of them.
Yeah, so you can acknowledge it, and what you can do is on the analysis, you can sometimes exclude it. This is called a sensitivity analysis, where you do the results with all of the studies, and then you do the results again without the studies that were biased. So if you want to, for some reason or another, still include the study, you can show, look, the study doesn't actually impact the overall results, so we can still leave it in. Or sometimes, if you're doing a qualitative study, you can include it, but just to strengthen the arguments of other studies. But in general, a better approach, in my opinion, is just to exclude them, because you've shown that they have bias. Typically, you would do this with 2 independent screeners, just to see if everyone gets the same information. Because as we're going to see soon, there's some level of subjectivity when you are ranking the studies.
How would you determine whether you exclude a study? So for example, sometimes you get a score, right?
Mm-hmm.
It's a numerical score at the end of a risk of bias assessment.
Mm-hmm.
And how do you then assign an arbitrary number by which you
Depends. So depends on the tool. So for example, some tools don't provide you an actual number, like the Rob2 or Robbins 1, but other tools do, like the Mirsky, for example. And then there's very set criteria. In the Mirsky, if it's below 11.5, you exclude the study. There's no arguing with it. But depending on the tool, you have some leeway and flexibility with how you want to use the score.
Mm-hmm. So for example, could you just choose, like this table you have on the screen now, could you choose to just accept the studies which have the green pluses at the overall?
You could do that, but then you're losing a lot of your studies. You could include them, but it's just important that if you are including something that is biased, you have done something to mitigate it, but most of the time you would exclude. So the red ones you probably exclude, and it's important that you're transparent about it. So in the methodology, you'd say, studies that did not meet suitable quality criteria are being excluded from this study. Perfect. Okay. So some key take-home messages. The quality assessment is more about the risk of bias. A paper can be really well written, present information that is really engaging, but it can still be vulnerable to bias. Always match the tool to the study design. Follow the tool guidance, not just your intuition. The tool will explain you how to use it, there will be summaries and criteria on how to use the tool. The summaries should be clear, transparent, and reproducible. You should outline on your methodology which tool you used, how you used it, what have you done with the results of the quality assessment, etc. And the risk of bias reflects how much we trust the results, not whether we like them. So that's very important when you're doing it. So these are some further reading. There's a book on epidemiology that's really good. It goes over different types of biases. Same with this Lecturio video series. And always the Cochrane Handbook is amazing. So now let's do a quality assessment together. So I've done it for this paper. Hold up. Can everyone see my screen?
Yes.
Yes.
Perfect.
Yeah.
So this is the Robbins 1 tool. To access the tool, you search on Google This is Rob2. If you search Rob2 on Google and you go down to risk of bias, you click here, and there will be the tool, the where to download the tool here. So there's many documents here on the full guidance of the document, the crib sheet summarizing the tool, etc. What I clicked on is the template for completing the assessment. Once you click on that, it will download the tool. It's 10 pages long, and you can see each domain, domain 1, domain 2, domain 3, on how to use the tool. And each of them you'd answer yes, possibly no, no, or no information for each of these. And then afterwards, you give an overall judgment on that specific domain. If you go here on the tool itself as well, there'll be full guidance document. This explains to you how to use the tool. It's a very long 72-page document explaining each step how to use this tool. So let's do it for this paper. So this is a paper that was recently published in the Spine Journal. The Spine Journal, in terms of impact factor, is the best for spine surgery. And this is a randomized control trial. So we're going to use the Rob2 to go through it.
Should we send this PDF on the Teams group chat so people can...
Yes, good idea, good idea. So I'll send it on the Teams. Yeah.
I don't know why it's not.
Oh, I can't share.
What if you stop sharing your screen and then try?
Let me share on the WhatsApp group. I think that's better.
Okay.
Okay, guys. So could all of you follow along with this paper? Okay. Does everyone have access to it on the WhatsApp?
I just got it.
You just got it?
Yes.
Right. Perfect. Good. So, okay. So for the first part of the study, was the allocation sequence random? So if you go down to the methodology of the study, most of the stuff you're looking for is in the methodology. They have a section called randomization. As you're hearing the randomization, they will explain the sequence was randomly created by Excel, one-time allocation. They explain how they do it, but you can tell that yes, it was randomly generated. Was the allocation sequence concealed until participant was enrolled and assigned to interventions? You can see here in the methodology as well that yes. So you can see that the operating surgeon only found out the surgery was going to do 24 hours before the surgery. And the participant also didn't know which surgery they received. However, I put as partially yes because it had a different type of scarring, a different type of decision. So both participants and the surgeon and the people following up would be able to tell which type of surgery the patient had. So blinding post-operatively was not possible as participants were made aware of, so it wasn't fully possible. So I put partially yes for this domain. Go to the next one. The baseline differences in intervention groups suggest a problem with the randomization process. So if you go down to table 1 in the study, you can see the baseline characteristics between each of the groups. So the midline incision and the paramedian group, you can see their age, their education status, a bunch of information on them, and it's pretty much the same. Usually they report p-values. In this study they didn't, but you can tell that it's pretty much the same. So I put a yes, no for this domain, as there's no differences between both groups after randomization. So my overall assessment for this domain is very low risk of bias. This is because randomization was randomly generated by Excel, allocation was concealed until 24 hours before the operation, and the baseline characteristics were well balanced, as we can see in table 1. Now, for the second domain, were participants aware of their assigned intervention during the trial? I put partially yes. This is because they could see the incisions they have. They have 1 incision or 2 incisions. So until the surgery, they didn't know what group they were in. But after the surgery, they did know. Were carriers and people delivering the intervention aware of the participants assigned during the trial? They were. I mean, 24 hours before they were, and in the follow-ups they were as well. again, because of the types of incisions the patients have. Were the deviations from the intended intervention that arose because of the trial context? Well, probably yes. So if you go down, there were 3 protocol violations that happened, and the 3 of them were because of pandemic and they couldn't account for. So if I Control F violations, you can see here, we did encounter 3 protocol violations whereby 3 patients received the incorrect operative approach. These violations all happened when COVID-19 restriction occasionally resulted in surgery cancellations in short notice. So there were some protocol violations, and they're being honest about it, but this means possibly yes. I put it in this domain. Were these deviations likely to have affected the outcomes? Well, I don't think so. It's only 3 violations, and look at the amount of patients they actually have. If you go to the randomization, they had 112 participants, and if you look on this graph, they had about 50 people per group. So not likely to have impacted the overall results. Were these deviations from intended intervention balanced between groups? Yes, they were. If you look, they were from each of the groups, so it doesn't really impact things very much. Now, this one is very important, 2.6. Was an appropriate analysis used to estimate the effect of assignment to intervention? They did not do this. So this is very important for randomized controlled trials. There's something called an intention to treat analysis and a per protocol analysis. And they did not actually conduct these, and they also did not calculate the power of their study as well. So an intention to treat means that from the moment of randomization, you're going to calculate this. You're going to calculate the outcomes. Regardless of who dropped out of the study, regardless of who was lost to follow-up, you're still going to include them in the analysis. A per protocol analysis is only the people that are left at the end of the study, so at the 12 months. So they did not report these. They did not make it clear on their study. So this is a source of bias. I put it as a no. In the last, and here, was there potential for substantial impact of these failures in the analysis to analyze participants in the group which they were randomized? I put yes, so there's no intention to treat analysis shown, which is very important for a randomized control trial. So for this domain, I put overall, there's some concern with bias. So there's 3 protocol violations. The trials were unblinded, which is almost inevitable when it comes to a surgery like this. And the analysis is descriptive only, with no clear intention to treat or how they actually handled patients who were misallocated. The same applies to this domain. It's very similar to the previous one. So the same point stays, that there's some protocol violations. There was the trial was unblinded, and the analysis is descriptive only. Now, when it comes to missing outcomes, were data for these outcomes available for all or nearly all participants randomized? I put as possibly yes. So if you look in the results, they have information from almost all the patients. There's a few who, again, were deviations from protocol, a few that were lost to follow-up, but overall, this doesn't really impact things that much. So overall, it's low. All patients had a 3-month follow-up. The primary outcome occurs early. They were looking at deep infections. And there's a minimal loss to follow-up and unlikely related to infection status. So overall, I think this is quite low bias when it comes to domain 3. Now, domain 4 was the method of measurement. Was the method of measuring the outcome inappropriate? So not really. So if you look at the randomization section here, they say all infections were confirmed by infectious disease physician after formal consultation. There was also a study monitor infectious disease physician who confirmed or negated possible suspected deep infection, performing both biochemical and imaging review. And they also follow specific criteria to diagnose the deep and superficial infections. So they followed CDC criteria with deep infection diagnosed by positive deep wound cultures or magnetic resonance with gallium enhanced to significantly increase inflammatory marker, C-reactive protein. So you can see that they had specific criteria, they had imaging criteria, and they have biochemical criteria to diagnose deep infections. So it's unlikely to have been biased by the subjectiveness of each researcher. So I put it as a no for bias for this department. Were outcomes assessors aware of the intervention received by the studies? They were, because they had to follow up, as we saw on the randomization section. They had to know who was in each group, so they weren't blinded. But this didn't really impact one group more than another, in my opinion. So overall, the risk of bias for this section is low because deep infections were identified using specific criteria. The diagnosis was confirmed by disease specialists. There were objective outcomes, so MRI, cultures, and CRP. And although assessments were unblinded, measures are unlikely to have been influenced, in my opinion. And now the last domain. Now this one is a very, very important one, in my opinion, very, very important. So this is the risk of bias in the reporting of results. So were the data that produced this result analyzed in accordance with pre-specified analysis plan that was finalized before unblinded outcome data were available for the analysis? So essentially, did they plan out what they wanted to do before doing the study? And it's impossible for us to tell. So this study was registered as a clinical trial. So if you search this number, NCTO, you can see the trial number, the registration number of this trial. And usually, once you find this, you can find a protocol. So if you Google this number, you're going to come to the clinicaltrials.gov, and you can find where this trial was registered. However, they don't have a published protocol, so you can't really tell if they just decided the analysis because of the results they were getting, or if they actually had things planned beforehand. So this is very important. We don't have information on this, and that could be a source of bias for the study. There's no published protocol, no statistical analysis plan, and no confirmation analysis decision were looked before the unblinded data. So this is something that's very important to catch on. Were multiple outcome measurements, example, scales, definition, time points within the outcome domain? And this is a yes, which is a bit unfortunate for the study. So there's multiple time points analyzed. They say that their main outcome is that they're looking at 3 months infection, but it's unclear when they decided it was 3 months infection. They were looking at multiple different time points. They're looking at 3 months, 6 weeks, 18 weeks, 1 year in the study. Sorry, let me go back to the study. And it's unclear if they actually just decided on 3 months because they found something significant, or if they decided on this time point before the study actually happened. So, and they're looking at multiple different factors, looking at deep infection, reoperation rate, patient-reported outcome measures. So what they could have done is just done the study, found something that's significant, and then reported that as the main outcome of the study. Hey, we have a question.
Yes, just with regards to the time points, would they usually be stated in the protocol if it was?
Yeah, so if you have a protocol, you usually should have the time points where they're gonna revisit the patients and see the patients in, for example, clinics or things like that. Also in the study itself, they'll tell you. So I have highlighted here, post-operative follow-up visits were completed by the surgeon at 2 weeks, 18 weeks, 1 year, 2 years, respectively. So they will follow along. However, if you look at the abstract and the main conclusions, they're talking only about 3 months. So it's a bit like, why? Well, why are you focusing on 3 months now if you're looking at them through all these multiple time points? Like, was the rest really significant? And then next, I could possibly ask for multiple eligible analyses of the data. There's no formal comparative analysis, and results were presented mostly like descriptive. So if you look at table 3 in this study, most of the results are descriptive. Yeah. So, and something that's very important is all that they did that is a bit sneaky. So the interim analysis, so they did an interim analysis and stopping rules discussion post hoc. So when it comes to interim analysis, it's an analysis that you do before the end of the trial, and you want to see like your results kind of halfway through to see if it's going, what direction it's going. And stopping rules are basically predefined criteria that allows you to stop a trial early. So if you think this is actually good, so we don't need to continue the trial, we know that this works. Or if you say, we know this is bad, we shouldn't continue this because we're harming people by continuing this, we should stop early. They only decided on these rules halfway through the study. So this is something that should have been decided before, because post hoc means decided after seeing the data. So basically, they only decided on analyzing the data and the rules for stopping after they had already seen the data for their study, and this is a source of bias as well. So I rated this as some concern, because there's still some information missing. There's some things that they kind of did a bit late, in my opinion. So my overall risk of bias for this paper is for domain 1 is low, domain 2 some concern, domain 3 low, domain 4 low, domain 5, which is the one we just discussed, some concern. So my overall assessment for this paper is there's some concern of bias. So this is very important because this paper is a very well-written paper if you read through it, very interesting results, published in the best spine journal in terms of impact factor out there. However, it is still vulnerable to some types of bias. So my main takeaway from this is that you're here to assess bias and assess where the bias could come from using these tools. A paper could be well written, a paper could be very interesting, a paper could have very interesting results, but still be vulnerable to bias. So this is a very crucial step in any systematic review. Does anyone have any questions?
You mentioned that the data was descriptive. Could you tell me a bit more by what you mean by that? Is it that they just put...
Yeah. Let me go back to this section, sorry. So they talk about confidence intervals, they select emphasis on between different groups and stuff like that. And if you look at table 3, table 3, this is their main outcomes and stuff, but you don't see many of their p-values, and they're also underpowered. So if you search for power, their whole point in their introduction is that we're missing a well-powered study on this, or the abstract as well, we're missing well-powered things. But then if you go to their methods, they don't do a formal power calculation, and they say that it was not appropriate to calculate power. So what can they really conclude here? I'm not really sure. I'm not sure if I'm being too critical of this paper, but it is a very good paper. It's just that it's a pilot, and you need better protocol, in my opinion, of what analysis they want to do and that kind of stuff. I'm not sure this is the best answer to your question, but yeah.
No, that's fine. Thank you.
Thank you. Cool. I think that's everything. Any questions from anyone else? Is everyone familiar now with quality assessment and how to do a quality assessment, the tools that are available, and how to choose your tools?
Yes, thank you.
Perfect. All right. Nice.
Thank you
That's
for that.
very good, Rodrigo. Thank you very much. Thank you for that very detailed process through risk of bias assessment. And thanks to everyone who was able to ask questions or gain clarification. For that last paper, pilot studies are usually underpowered because they're only just a proof of concept. They're just a snapshot of what is possible. That's why they're called pilot study. So they're underpowered, hence then you can't actually make any proper conclusion from them. So in fact, for a pilot study, you can't actually calculate. Well, no, you can't, but you would usually not calculate sample size required. You usually don't do that because you're only just doing a small cohort. But yeah, so probably if that paper was a proper multi-center randomized control trial, it probably would not have scored that low in the risk assessment. But think of it this way: you can see what Rodrigo said. It was a paper published in the Spine Journal. It was a randomized control trial. Anybody could be thinking, "Oh, randomized control trial is high in the evidence triangle, so it should be fantastic. We should give it the best scores." But from what he said, you need to take your time and go through each of those components. And I know Shiraz was asking about what are those tools. I hope now you can see what those tools are, how we use them. They're all online. You don't need to do anything. You don't need to have them on your phone like a calculator, but download them, go through each of the paper. And nice thing about the papers is when you do systematic review, we tend to assign. So for example, if we assign you 2 papers or 3 papers, depending on the number of papers and number of people involved in the study, and we assign you those papers to extract the data, we also expect you to do the risk of bias assessment for those papers as well. So the information you get from reading the paper would help govern what happens in the grand scheme of things. But yeah, so thank you guys. I hope everything has been clear enough so far. Next week, we're going to be wrapping the series on systematic review with describing how to perform some descriptive analysis, how to actually interpret some basic systematic review analysis. And then I'll take you on how to actually write a systematic review, the process of writing a systematic review, basically. But yeah, I will stop recording now.